Welcome, everyone. I think we'll go ahead and get started. I'm Laura Gonsiorek. I'm the Senior Associate Director of the Nicola Center for Ethics and Culture here on campus. And it's been quiet on campus for the last week or so after graduation, so it's nice to see the classrooms somewhat full again. I want to thank, before we get started in a special way, the class of 1963 for sponsoring today's panel, especially Ed Conlin, who's worked so hard with my own colleague, Ken Hellenius, to plan today's event. Before we get started with the panel, I'd like to briefly introduce you to the work of the Nicola Center. We were founded in 1999 by Professor David Solomon, now an emeritus professor of philosophy here at Notre Dame. We are founded as an academic center in the College of Arts and Letters, dedicated to research, teaching, and service in support of Notre Dame's distinctive Catholic mission. Today, our director is Professor Carter Sneed, who's one of the world's leading experts in public bioethics and a professor at Notre Dame Law School. He's unable to join us today as he's just returned from international travel, but I hope that I will be an okay substitute in his stead. The center's mission is to share the richness of the Catholic moral and intellectual tradition at the highest level and across the range of disciplines, both here on campus at Notre Dame and then as Notre Dame in the public square. And I think that'll be a kind of recurring theme in today's conversation, that we're searching for ways to affect change in the world, not just here on campus at Notre Dame, but also as Notre Dame in the world. So we seek to pursue that mission in 4 interrelated areas of focus. First is student formation, second, culture of life initiatives, third, research and publications, and finally, mission stewardship. And for the sake of today's conversation, I'll share a bit about 2 of those areas before we start. So first is our efforts for student formation. The flagship program in our student formation program is the Soren Fellows Program, founded in 2014, after Father Jenkins called campus to honor Father Soren, the founder of our great university, who challenged us that Notre Dame could be a force for good in the world. So the Soren Fellows Program was founded within the Nicola Center as an integral formation program in the Catholic tradition. So the program itself provides students with opportunities to deepen their faith lives, to develop lifelong friendships, to consider enduring and contemporary issues through the lens of the Catholic tradition, and to prepare for lives of service beyond the university in defense of human dignity and of the common good. Now today, in 2023, we have over 450 undergraduate and graduate students in formation in the Soren Fellows Program. We offer over 150 programs and initiatives each year for them to engage with the Catholic moral and intellectual tradition. And just this year alone, we've offered over 200 grants to support their research, internships, service, and pilgrimage opportunities throughout the year. Second, I want to highlight our culture of life initiatives. And, our goal is to aim to be the leading kind of engine of pro-life activity here on campus at Notre Dame, and then again, as Notre Dame in the world. And our newest effort within our culture of life initiatives is the Women and Children First initiative, which is really the driving force, what brings us here today. So knowing that building a true culture of life requires deep, comprehensive attention to the needs of women, children, and their families, the Nicola Center launched this initiative to undertake interdisciplinary research, teaching, service, and public engagement around the many interlocking questions at the heart of building a culture of life. These questions include the legal, policy, social, and ethical dimensions of issues regarding healthcare, housing, education, employment, poverty, racial justice, religious liberty, international human rights, and many others. So that brings us to today's panel. Our panel today aims to present practical steps that we can take to build and support a culture of life that welcomes and celebrates women, children, born and unborn, and their families. The experts we have here will address common myths about medical care for women who experience challenging pregnancies and miscarriage. It will discuss efforts to provide comprehensive care for women and families experiencing poverty and marginalization. We'll explore the contentious legal and media landscape post-Dobbs and highlight ways to support families and children with intellectual and developmental disabilities. You'll find the full speaker bios on the handouts that we distributed before today's panel, but very quickly, we're thrilled to be joined by Mary FioRito here at the end, who is the Cardinal George Fellow at the Nicola Center for Ethics and Culture and former Director of ProLife Activities for the Archdiocese of Chicago. Next to Mary FioRito, we have Mary O'Callaghan, who's a public policy fellow of the Nicola Center and a faculty fellow in the Master of Autism Studies program at St. Mary's College. Her current research focuses on ethical issues related to disability selective abortion. Kate Callaghan is next to me here, who's a graduate of Notre Dame and currently associate director at Memorial Hospital's family medicine residency program here in South Bend and a practicing family physician. And then finally, we're joined via Zoom by Monique Chireau, who you see ominously above me. Monique is an obstetrician gynecologist with more than 30 years of clinical experience and a senior public policy fellow at the Nicola Center. Monique is joining us via Zoom today because she is actively on call, so you'll have to forgive us if she ducks out to deliver any babies. So each panelist has delivered remarks in her area of expertise, and we'll begin with those remarks and then follow with a discussion of how their expertise might inform how we pursue support for women, children, and families in our own communities. I think because Monique is with us now, we'll go ahead and let Monique go next.
It's a real pleasure to be here and an honor. As Laura said, I'm Monique Wubbenhorst. I'm a board certified OBGYN and senior fellow at the Nicola Center. So as a clinician and researcher, I'd like to talk a bit about challenges and opportunities for the pro-life movement post-Dobbs. Since the Dobbs decision, we've been hearing many things, that a miscarriage is the same as an abortion, that treatment of an ectopic pregnancy is the same as an abortion, and that women won't be able to get care for life-threatening problems during pregnancy. We've heard also that maternal mortality, especially among minority women, will go up, and also that medication abortion is safer than Tylenol or Viagra. Each of these is untrue. First, by definition, abortion is intentional feticide. Its goal is always to kill an unborn human being. There's no doubt that the developing embryo and fetus are human because they have human DNA and human parents. This is human life. It's not dog life. It's not salamander life. It's human life. And all laws restricting on abortion focus on intentional feticide. That is to say, procedures that intend to kill the unborn child, which is an essential moral and ethical distinction. Intent matters in medicine just as it does in law. Elective abortion is always intentional feticide and always morally wrong. So miscarriage is being portrayed as criminal post-Roe. Miscarriage involves removement of the deceased embryo or fetus. Elective abortion kills the embryo or fetus. These two goals are entirely different. Restrictions on abortion also do not limit a physician's ability to treat an ectopic pregnancy. Treatment of an ectopic pregnancy is not an abortion. With an ectopic pregnancy, the developing embryo is in the blastocyst stage and implants outside the uterus, and without treatment, eventually causes a fallopian tube or other sites to rupture and bleed with catastrophic hemorrhage. Treatment of an ectopic pregnancy is not intentional feticide and is not prevented by any current law restricting or banning abortion. So the difference between miscarriage, ectopic pregnancy, and elective abortion is therefore very clear. In a miscarriage, the baby has already passed away, therefore any treatment is not an abortion. Treatment of an ectopic pregnancy requires removing a living embryo, but the goal is to save the mother's life so that both lives are not lost. In contrast, an abortion is always intentional feticide. We've also heard that abortion restrictions will keep women with life-threatening illness from accessing care. This is not true. The goal of such care, again, is to save the life of the mother, and if possible, to save the life of the unborn child. OBGYNs have been treating, like myself, they've been treating women with cancer, high blood pressure, and other serious diagnoses during pregnancy for more than 100 years. In fact, I have white hair or gray and white hair, but I was trained by people who, 30 years ago had gray and white hair. And they were experts in their field at a time when abortion was illegal. No one questioned the need to use reasonable medical judgment to provide the best care for women then, and life-affirming physicians do not question that and do provide that care now. There are some claims that abortion is needed to reduce maternal mortality. No study based on data collected from patients shows that abortion reduces maternal mortality or that legislative restrictions on abortion increase it either. Studies that purport to do this are based on statistical estimates only. And in fact, El Salvador, Chile, Poland, and Nicaragua, which enacted legislation restricting or prohibiting abortion many years ago, did not see increases in maternal mortality. In contrast, when South Africa legalized abortion, maternal mortality increased. When Chile and Ireland had some of the lowest rates of maternal mortality in the world when abortion was completely illegal in both countries. We in the US, in contrast, in comparison, have had nearly unlimited access to abortion for nearly 50 years. We have also some of the worst mortality rates and preterm birth rates in the developed world. I want to speak briefly about abortion's effect on minority communities. Abortion has devastated minority communities. After Roe v. Wade, the number of abortions in African-American women more than tripled in 20 years. More abortions are performed in African-American women than any other ethnicity, even though we constitute only 13% of the US population. And among, as I said, we have both the highest abortion rates and the highest poverty rates. So if abortion was essential for women's economic empowerment, these two facts could not be true. Similarly, among racial and ethnic groups in the United States, we have African-American women have both the highest rates of abortion and the highest rates of mortality. Both these facts cannot be true if abortion reduces maternal mortality. 17 million abortions later in the Black community, our communities are depopulated, and we continue to have high rates of abortion, deaths from abortion, preterm birth, maternal mortality, and poverty. None of these has been fixed by abortion. And as people who care about justice, we rightly see this as a problem. There's finally been a push to increase the use of medical abortion, also called the abortion pill. It's been said that medical abortion is safer than Tylenol or Viagra, and there's quite a bit of data to show that this is not true. There are very significant complications, including hemorrhage, which are associated with medical abortion. And a review of data from England show that once liberalized use of medical abortion was enacted, especially during COVID, there was a rapid increase in the number of ambulance calls and hospital emergency room admissions for hemorrhage. Another important fact is that if you quickly, just briefly look at the prescribing info for mifepristone, which is a component of the medical abortion regimen, it has a black box warning. This is the highest warning, or not the highest, the second highest warning. It's a warning required by FDA when a medication has significant side effects, especially in specific populations of women. Neither Tylenol nor Viagra has a black box warning. And so therefore, it cannot be said that this drug, mifepristone, is safer than Tylenol or Viagra. I'd like to close by briefly mentioning that what women really need and what we see in OBGYN and in pro-life work is they need quality care, compassionate healthcare professionals, support, and better health education. One of the problems in many communities is access to care. But in addition to that, women need a vision for their future and a future and hope. Communities and civil society, which is all of us, not just professionals and not just the academy, need to support couples and their families as they chart their way through life. This is something that everyone can do. The pro-life movement is continuing to grow and spread and flourish at every level, despite some incredible adversity, because it carries the message of healing and hope and restoration for both men and women. You can do this. You can be a father. You can be a mother. Motherhood and fatherhood are beautiful. Family is beautiful. Life is beautiful. And this is where all of us, civil society, so to speak, can help. This is about ending abortion as a moral and social evil, yes. But it is even more about a vision of human flourishing, and as we say at the Center for Ethics and Culture, to build a civilization of love. Thank you.
Thanks, Monique. Harry.
Thanks so much, Laura. So I am here to talk to you today about caring for a relatively small, at least in the overall picture of abortion, but very important group of vulnerable individuals and their mothers. I'm going to include fathers here because in these cases, the father is often, most often, still in the picture. So really the families of infants who receive a poor prenatal diagnosis or diagnosis of a disability before birth. A colleague of mine at Notre Dame says that whenever you teach, you should impart three things: knowledge, skills, and a disposition. This model works well here because the issue of disability selective abortion is not as well known as typical abortion. So I want to arm you with a little bit of knowledge. It's hard to address the problem unless you understand it. Second, because the dynamics of risk are a little bit different here. I want to give you some usable skills and points of entry at which support is needed. And finally, I want to end by appealing to your hearts and give you some motivation for stepping into this arena and encouraging others to do the same. All in 5 minutes or less, I promise. Okay, so first some basic knowledge. The most readily available statistics, which you might have heard in this area, have been collected on infants with Down syndrome. It's estimated that under Roe, somewhere between about 67 and 90% of children positively diagnosed with this disorder lost their lives to abortion. And abortion rates for other children are likely similarly high. We just don't have good statistics in this country. In spite of this, some legislative progress has been made. In 2008, there was a bill mandating that accurate information be given in the case of a poor prenatal diagnosis, so given by the physician. who was attending the case. And by 2022, 6 states had outright bans against this practice in effect, with 6 more states with bans that had passed but not currently in place. Okay, so where do we stand after Dobbs? The good news is that in the 24 states, 24, 25 maybe states, where restrictive abortion legislation has either gone into effect already or has been proposed, but is currently challenged, so it's kind of in limbo in the courts in some way. Only 3 of these, or less than 10%, allow abortions in the case of disability. And these only when the disability is very severe or life-limiting. To be clear, I'm very firmly opposed to abortions in these cases. We can talk about this more, but we're going in a hopeful direction. So what practical skills can I impart to think about how to support infants and families with disabilities in states where disability can still mean a death sentence, or in states where this is not permitted? And obviously, we all know there is lots of interstate traffic as well. So this is not sort of a neat demarcation, but at least it allows us to sort of think along these lines. So let's start with the first case about how to support infants and families when abortion is still allowed. Here, the most acute need by far expressed by parents is still going to be to support mothers of children with disabilities around the diagnosis and birth. It's helpful to realize that the context, right, is a little bit different. These are women you may not meet at your local abortion clinic or crisis pregnancy center. They are in crisis, right? They're given usually a small time to make a decision about the life of their child in a very short time span with a lot of pressure. But much of this is unfolding in the OBGYN's office. So ideally, we want to change the encounter here, right? To educate physicians, to offer compassionate support to the mother and extend what we might think is so basic, right? All the skill and care of a good physician to the patient in utero. But even without changing physicians' practice, we can support mothers through freestanding support organizations and ministries that accompany parents during this time. The model of perinatal hospice, right, caring for a child in utero, as you might in a typical hospice, but where the mother, right, is the site of this care, is perhaps best well known and most effective, and it's very adaptive. So it can support infants who are not right in sort of severe medical crisis as well, like infants with Down syndrome. And often these kinds of ministries or organizations are staffed by volunteers. So this is a place where we can all have some effect. In states where disability abortions are no longer allowed, there's still a need for support around diagnosis. There's a strong need, but there's so many opportunities as well. With abortion off the table, we can begin to consider how best to use prenatal diagnosis, right? Maybe we don't need to require prenatal diagnosis in every case. How about diagnosis in the service of treatment and compassionate care, right? It's not a novel idea. This is how diagnosis has typically been used in medicine. But it's not been used, right, in the area of prenatal medicine in this way. In states where disability abortions are no longer allowed, we can also begin to work to become exemplars of communities, because other states are going to be watching us. They're going to be, what happened to those states that are allowing all those children with disabilities to be born, right? So we can become exemplars of communities that not only welcome those with disabilities at birth, but pledge commitment to families and those with disabilities that will continue right throughout their lifetimes. They'll be surrounded with care. Might it cost more resources? Absolutely. But we need to be the kind of society that says, bring it on, right? Yes, there's a price, but that's the price of remaining human. Which brings me to number 3. Why should we care about mothers and their children with disabilities? It can be tempting to get sentimental here. I've been in legislative hearings where some argue that the lives of children with Down syndrome should be spared because they're always happy, or because their presence makes us better people. And there's obviously some truth here, but this is a shaky defense of life. My son has Down syndrome and autism, and he has plenty of bad days. And many people don't feel the need for the help of the disabled to be virtuous, right? There's always rescue pets if you need to feel good about yourself. We need firmer ground to stand on here. So under the shadow of the dome, of course, we can speak the truth. God made those with disabilities like all of us in his image, and they have immeasurable dignity. We know it's reprehensible to destroy any human life, right, given by God as pure gift. But what about when you leave this campus and encounter others who don't share this belief? Can you appeal to those, right, who don't share your faith? And absolutely you can. Legislative arguments and judicial opinion in this area increasingly point to a consensus that these abortions are eugenic, targeted at eliminating weaker persons. And this practice has already been soundly condemned after our country and other countries witnessed the fallout of eugenic practices during the early part of the 20th century. Although our primary concern, of course, is with the lives of those with disabilities, ultimately, this practice harms all of us. German theologian Karl Barth noted at the German war crimes that a society that destroys its weakest members, and I can't imagine anyone weaker, right, than a child who is not only in utero, but has a disability. Any society that destroys its weakest members is on the verge of collapse. So we all have a stake in this. But let's end on a positive note, because the converse is also true. A society that cares for its weakest members, it cares for those with intellectual disabilities, it cares for those with physical disabilities, with God's grace, right, will flourish. Thank you.
Thank you, Mary. Kate?
Well, yeah, it's an honor to be a part of such an engaging conversation. And honestly, several of my comments will echo those of the panelists before me. As was mentioned, I'm a family medicine physician, and I work in primary care here in this community. And while I'm not a parent myself, I not infrequently tell both my patients and my friends who parent that, in my opinion, parenting is the hardest job on the planet. And I think arguably it's some of the most beautiful and rewarding and fruitful work that somebody can do on this earth. But I also think it's important to emphasize that its beauty and its reward, its fruit, none of that is a product of it being easy. Quite the contrary. I believe that's true for anyone who's a parent, but I also believe that that hardship is enhanced oftentimes exponentially when someone becomes a parent under unplanned circumstances amidst any number of other hardships that they might already be experiencing in their lives. And as a family physician, I've seen this time and again. I get the privilege of accompanying individuals from birth to death, many from low socioeconomic status households in my practice here in South Bend. And it's nothing short of astounding to survey the vast number of obstacles that so many women with socially complex pregnancies must overcome in their journey as parents. Increasingly, the primary care community is recognizing the necessity of something that has been termed trauma-informed care. To me, this is just love under a scientific title. But trauma-informed care is rooted in neuroscience that reveals to us that sensory experiences and caretaker relationships can create toxic stress, trauma, that dramatically impacts brain development. Many of my patients and their children have been exposed to these kinds of toxic stresses in abusive relationships, in racist interactions, and in witnessing those that they love endure these kinds of physically and emotionally violent encounters. These repeated stressful and chaotic experiences make it difficult for them to hold a job or pay their bills or ensure that food is on the table for their families. But the challenges are even more fundamental than this. Things like establishing routines and setting limits and creating an environment of safety physically and psychologically for their children, all the time seemingly small yet hugely significant factors that facilitate kids' healthy growth at every stage of development. These are so much harder for moms who maybe never had any healthy parental model available to them, who have immense internal and external obstacles to overcome to be able to parent well. With that background in mind, and with the help of some of the extraordinary colleagues and friends I get to work alongside in this city, I want to offer you a few strategies from my perspective for building an authentic culture of life in the spaces that you inhabit going forward. Firstly, if you feel so led, consider participating in or financially supporting programming that sticks with moms and their children for the long haul. It's so encouraging to me to hear about places like Heather's House or organizations here in South Bend, the Women's Care Center, folks that really stick with individuals and seek to serve them. Try to become aware of these programs and try to ensure in any way that you can that equitable access for these programs is available regardless of race or socioeconomic status. I think increasingly we need to think outside the box and harness our creativity and innovation to find novel approaches to these kinds of wraparound services for marginalized women and families. Secondly, if you're a clinician or work in a helping care space, or maybe you know one, or you see a clinician yourself as a patient, I encourage you to be patient and flexible. Underserved individuals have often been formed in chaotic, impulsive, and disorganized environments. We need to have empathy for them that recognizes that it makes a lot of sense that they personally continue to really struggle and experience this kind of chaos and impulsivity and disorganization, both internally and externally. They will have lots of good reasons to be late to appointments. to require multiple repetitions and explanations before things really click. And there will be sacrifice for clinicians and honestly, as well as patients in doing this work well. Doctors who care for underserved individuals oftentimes have to sacrifice efficiency to do this work well. And consequently, their other patients being seen end up waiting longer for appointments. This is certainly true in my practice. I see a range of individuals. Certainly the predominance of my practice is low socioeconomic status individuals, but I see several other folks that could get their care anywhere they wanted in the city, and they sacrifice something in coming to my clinic because lots of my appointments kind of go off the rails in terms of what I anticipate is going to be the main concern for that patient in a given day. This is a real sacrifice, but it's one that I would encourage all of us to be willing to make for the sake of cultivating the common good. This is part of what it means to live Matthew 25, to be with and for Christ in, as St. Teresa of Calcutta says, the distressing disguise of the poor. What would it be like the next time I'm waiting in an office to think about the reality that my waiting for my doctor for a few extra minutes might actually be a gift of service to a marginalized individual in my broader community who needs more time to unpack her story? Lastly, I think moms need people, or at least one person who can walk with them through each stage of parenting. In preparation for this talk, I spoke with a friend of mine who fostered a child whose mom unexpectedly became pregnant in college. This woman had a sky-high IQ, but she was failing out of her undergraduate program. She was immature and undiagnosed with PTSD, and amidst all this was attempting to navigate her role as a parent. There was no way that she could nurture a child and, in addition, support her own healing while navigating her current state of life. However, with my friend and her family coming alongside her, she was able to complete her bachelor's degree. She pursued and persisted in the hard work of counseling and processing her own trauma, and she ultimately gained financial stability. Her son graduated from high school last spring, and my friend feels deeply that this young man didn't need a better or a different parent. He needed his mom, but he benefited immensely from his mom having another mother who had ventured through parenthood already with her 3 children and was willing to be just a text or a phone call away at every season of his development. I'll be the first to admit that this is hard work. It's work that humbles me every day and reminds me of my need for Christ's grace and for his mercy. And to whatever degree I live into any of the approaches that I just named, it's in large part because I work in an extremely supportive culture with a fabulous social worker and colleagues who understand these additional layers of complexity and not only make me a better clinician, but a better person every day. It's also in large part because I have extraordinary friends, like my friend Gwen, who I was talking about earlier, who set the bar for me in terms of what authentic, whole life care really means. As a disciple, I feel increasingly convicted that this work of full thickness, innovative, attentive accompaniment of the vulnerable, underserved in our society, so often women and children, is not ancillary, but rather central to bringing the good news to light in our broken world. We each have unique ways in which we alone can further that work every single day. So I leave with you a question of what might your contribution be? Thank you so much.
Okay, if you please join me in thanking all of our panelists. Now, before posing a question to the panel, as a Catholic university, we all, I hope, know that Notre Dame is committed to life and to providing resources that support the choice of life. So in order to kind of explore what Notre Dame's own efforts are to build a culture of life and civilization of love, I wanted to highlight a number of things that we do on campus here to support pregnant and parenting students and their families. Just get the conversation going a little bit. So all of these policies apply to both undergraduate and graduate students here on campus. The Notre Dame Family Resource Center has a program director and is the official pregnancy support advocate here on campus at Notre Dame. The University Counseling Center offers confidential 24-hour crisis support via telephone, in-person counseling, and provides ongoing support. Campus ministry provides spiritual and counseling support both in the residence halls and with drop-in hours here on campus in Coleman Morse, where they're located. University Health Services provides free and confidential pregnancy tests here on campus. Notre Dame University provides full support to unexpectedly pregnant students here on campus and will do all it can to accommodate needs and concerns about coursework and housing. This is sometimes a myth here on campus that I've certainly heard articulated, but unexpectedly pregnant students are not subject to disciplinary action here on campus if they do find themselves in that circumstance. Those students are allowed to remain in their residence halls so long as that's where they're comfortable living for the duration of their pregnancy, and then are provided with suitable housing for parenting once they've had the child. Notre Dame Right to Life Club here on campus, which is the largest undergraduate club here on campus, provides regular free on-campus babysitting to students, undergraduate and graduate students who are parenting during their studies, and even to staff and faculty here on campus. Right to Life hosts Project Mom, which includes baby showers to provide direct material support to women and their children over the last number of academic years. Locally, the Right to Life Club supports the Women's Care Center, which is a nonprofit organization dedicated to serving mothers and families at 3 different locations here in Michiana. Right to Life also provides volunteer support to Hannah and Friends, which is a nonprofit foundation dedicated to providing a better quality of life for children and young adults affected by autism and global delays. And one more thing the Right to Life members also support is volunteering at Hannah's House, which is a maternal home that provides safe environment, programming, and support for the physical, emotional, and spiritual well-being of young pregnant women in our community. So I think, that's a little bit of what Notre Dame does here on campus. And I mentioned earlier that the Center for Ethics and Culture, its mission, we're devoted to not only working here on campus, but also finding ways that we can project Notre Dame's distinct voice into the world. And I think we not only have an opportunity to do that, but somewhat because of our mission of responsibility to do that and to form future global Catholic leaders that will seek to build a culture of life and civilization of love as they discover and pursue their vocations here on campus and then again in the world. So the Center for Ethics and Culture specifically, I mentioned our Soren Fellows program earlier. It aims to be an opportunity for students to receive integral formation in the Catholic tradition during their time on campus, such that it will inform their future vocations as they go out into the world, whether it be professionally or personally, again, to build a civilization of love in the world. The principles that animate all of the work of the De Nicola Center, to name a few, are radical hospitality and friendship in all of our work, in all of the areas that I spoke about earlier. We undertake our efforts in friendship with one another, and friendship with those that we agree and with those that we don't. And our director, Carter Sneed, in his book, What It Means to Be Human, discusses and explores the idea of networks of uncalculated giving and graceful receiving. And we attempt in all of our efforts to kind of provide a ministry of presence here on campus and exhibit in a unique and consistent ways the virtues of integral formation and also the values of the university, such that we can instill those in our students in a really whole and thoughtful way. And then they leave this campus and one day are sitting here out in front of us, having lived those things outside of campus. And finally, the Soren Fellows program, we really aim, the university's mission statement says that, we are to provide a sense of community and of responsibility that prepares students for subsequent leadership in building a society that is once more human and divine. And I can think of no better aspiration for our Soren Fellows program than to build that type of civilization. So I think with that, I will pose a question to our panelists, and all of you did a wonderful job kind of weaving in your reflections, some examples of what you've seen in your own work. But I wonder if, again, in that spirit of, now that we've discovered or explored a little bit of what you're doing in your own work, what Notre Dame does here as a community at Notre Dame, how we might, or how the people in this room could help support women, babies, families, and build a culture of life off campus in their homes, whether it be through direct efforts, advocacy, or any number of other things. Monique, do you have anything to add?
Yeah, I feel as though we, again, as I think I may have alluded to, we look at kind of the sort of spectacular battles between in the clinical realm, but really, and also look at kind of the legislative, back and forth in different states. But I would venture to say that that's the air war. The ground war is civil society. It's everyday people providing support, and also not just providing support to women who have pregnancies that were unexpected, where they're abandoned, but also in helping to convince people of the fact that abortion is a moral and social evil. And that can be very difficult. It can be kind of intimidating at times. But what I think is helpful is that when we're able to arm ourselves with facts and try to portray those facts with the humility and the grace of Christ, not portray, but to present those facts with the humility and the grace of Christ, people generally have one of a couple of reactions. They'll say, I'll think about that, or they'll just, argue and fight with you, in which case you say, look, these are facts. And I remember a pastor saying this, it was a very interesting statement. She said, it's at a women's conference last year. She said, we all have the same facts in front of us, but it's our individual stories that cause us to view these facts differently. And so sometimes facts alone are obviously not enough. We do need, as I said earlier, to show the compassion, the humility of Christ. But at the end of the day, you can say, okay, if you have a different set of facts or facts that are sort of in opposition to what I'm presenting, let's pull those out and let's talk. And then finally, I think another fruitful way to engage is when people just disagree, have very strong feelings, is to say, can we agree? We are not going to agree on this, on the issue of abortion. That's not going to happen. But can we agree that it's important to support women, children, and families? It's important to try to help people to get access to the things that they need, as everyone is discussing, and focus on that. And that can also be a fruitful way of doing things as well.
Okay, I'm going to probably expand on Mary's theme, because if in general sort of unplanned or unexpected pregnancies are met not with joy, but with sorrow or some kind of disdain, you can imagine what it's like to have a child, or horror, what it's like to have be expecting a child with a disability. When we've met parents whose doctors react right away. Okay, I'll just schedule you for an induction, and a therapeutic induction, a euphemism for abortion. But I can't even probably express how painful it is as a parent, right? When your child is born or when your child is diagnosed, and to have others greet them with a sense that it would be better if they weren't there. I have 5 children, and our last children, our 5th child, Tommy was born with Down syndrome. And when all the others were born, the delivery room was just, exciting. It was filled with excitement and lots of chatter. And, he looks like mom, or he looks like dad, or whatever it was, or what color hair does he have? When Tommy was born, the room went silent, like dead silent. Nobody said a word. It was the most horrible welcome you could imagine. Nobody said, welcome to the world. I'm so glad you're here. Congratulations. It really has stuck with me. And so I think that anything you can do, right, to provide a welcome for children with disabilities. Those with disabilities, often these occur across the lifespan, but because of legislation, Americans with Disabilities Act, et cetera, there are a lot of services provided. We have, inclusion in schools, there are services for adults, et cetera. But we do a horrible job of welcoming new babies with disabilities in this country. And so one thing you could do is be part of an effort that welcomes these children. A lot of times local Down syndrome groups bring new parent bags to the hospital. We do that, like filled with books and maybe onesies and a blanket. So call up, a local disability support group, like a Down syndrome group, and say, do you support, new parents? Can I help you? Can I donate to that? Or can I be part of that? Or it doesn't have to be Down syndrome. You could go to the NICU or to the mother baby unit at the hospital and say, I'd like to volunteer. Like when you have a family who has a child who's born with a disability, I'd like to volunteer something. Can I give you gift cards to give to that family? Can I give you even a simple thing like a card, a welcome card, a blanket, some clothing, a gift bag, something that would say welcome, because we're not doing it right now, and it would absolutely change, right? That family's life to think that their child was wanted, right, by the community. So yeah, again, really just kind of seconding what Mary says, but so important with individuals with disabilities.
Yeah, honestly, most of my recommendations or my thoughts about this, I tried to capture my remarks, but my biggest encouragement would be to try to choose one thing, however small, and to stick with it. And if it's one relationship with one person who might have an isolated need, that's fantastic. If it's a commitment to a particular organization and exploring more about that and keeping to it, I think that's great too. But I also would say within that one thing, to try to build relationship with somebody whose background might put them in a situation of crisis. I loved Mary's distinction between the crisis and the pregnancy. And I think I'll speak for myself, having come from just an abundance of privilege. it's really easy for me to lose sight of the complexity around the situations that individuals find themselves in. And it's extremely humbling as I get to know and build relationships with the patients in my practice to recognize the ways in which I make assumptions that are just not accurate. And so I think anytime I can lean a little bit further into relationship with someone whose background is pretty different than my own and have some genuine curiosity and try to hold a posture of making generous assumptions within that, I move myself more towards a culture of life. And I think inevitably the world, I pray, benefits from that too. So I don't think it has to be a big thing, but whatever the thing is, to try to stick with that and really build a relational foundation within that.
Great. Well, as we close today's panel, I'd like to kind of call us back once again to Notre Dame's own mission statement, which articulates in the closing line that Our Lady's University must pursue its objectives through the formation of an authentic human community graced by the Spirit of Christ. So I'd like to thank you all for joining us today as we work together to build that community in support of women, children, and their families. Again, special thanks to our panelists, to Ken Hellenius, Ed Conlin, and the class of 1963 for all of their hard work to be here today. We hope you enjoy a beautiful weekend of friendship here on campus, renewed by a sense of all that Notre Dame has given to us and all that it will continue to offer to the world. We are so happy to have you here, and go Irish.